Welcome to my YouTube channel. Today we are going to talk about the management of twin gestation. Kindly subscribe. It will cost you nothing, actually nothing. So kindly press on the subscription button and let's move. So before we begin the management of twins, we are going to talk about the types of twins. So there are two types of twins. There is the fraternal twins and there is the identical twins. So the fraternal twins is formed when we have two eggs and they are fertilized by two different sperms. While the identical twins, we have one egg and one sperm, and later when they form a zygote, it divides later. So I hope you have really understood. So that monozygotic twin can be of four identical, where we have dichorionic, diamniotic, monochorionic, diamniotic, monochorionic, and conjoined twins. We are going to talk detail. So during formation of the zygote, later after several hours, we form morula, where it's replications, mitotic replications of the cells. So that when that during that stage, when 1 to 3 days, when cleavage or separation happens on that time, we have dichorionic, diamniotic twins. These are twins who have different placenta and have two different gestational sacs. While after morula is formed, later we form blastocysts, that is 4 to 8 days. When cleavage occurs this time, where we already formed the inner mass, then we have monochorionic, meaning one placenta. However, they have two different amniotic sacs. So we'll have monochorionic, diamniotic. So in the third one, where we have implanted blastocysts, which is the blastocysts are already implanted, that is 8 to 13 days, we will have monochorionic and monoamniotic, meaning we have one placenta and one gestational sac. Whereas when division occurs, we have already formed the embryonic sac, that is 13 to 15 days later, because embryonic sac is where we get all of our organs. For example, we form the epiderm, the endoderm, and all that. So, meaning if division occurs after the forming of the embryonic sac, we are going to have conjoined twins. They are going to share some of the organs. So let's dig in the management. So in the management, obviously, you're going to start in the antenatal period, where you'll advise this mother to take dietary supplementation and increase calorie intake, because obviously they are feeding for 3. Not if you have had like women say I'm feeding for 2, but now they'll be feeding for 3. So in the second trimester, you advise them to increase stress to decrease the risk of rupture of membrane. In addition to that, because they are carrying two pregnancies, meaning the demands of the nutrients increase and the supplements, so you advise increase of supplements such as iron, which will reduce the risk of anemia, and calcium and folic acid. In addition to that, close ANC, which will look out for complications of multiple gestation, which include anemia, preeclampsia, in addition to fetal surveillance and malpresentation. The visit, the frequent visit should be at least once a month, because this pregnancy is a high risk pregnancy. Fetal scans for the babies should be done 3 to 5 weeks. So during the intrapartum period, during the delivery period, so we have we have 3 modes of delivery, where we have vaginal delivery, where we have cesarean delivery, and where we have assisted delivery. However, today we're going to talk about the two. There's the vaginal delivery and the cesarean delivery. I hope we are good at that. So we said we have two types of twins, where we have the fraternal twins and we have the monozygotic twins, the identical twins. So in terms of the fraternal twins, it's simple. So if the vaginal delivery can occur when both twins are at cephalic presentation or vertex presentation, or at least the first twin is at vertex presentation. That is for the fraternal twin. I hope you are okay. Now, on the monozygotic twin, if it is die, then we have a leavage, because these twins have their amniotic different amniotic sac and different placenta, meaning we can do vaginal delivery. So, and we can only do vaginal delivery when both twins are at vertex presentation, or at least the first one is at vertex presentation. We're going to see the indications or the role of CS in the next slides. So during the first stage of labor, so it just plays out like singleton. So we will do the various steps of the first stage of labor and the second stage of labor. So in addition to that, we'll also require like skilled individuals, that is obstetrician, anesthetist, and neonatology, because already we are having multiple gestations. So one could be overwhelmed in case the two need attention. Patients should be in bed rest to prevent early rupture of membranes. In addition to that, you do fetal monitoring. So ABE should be done as soon as rupture of membrane occurs to exclude risk of cord prolapse. So cord prolapse is a complication of multiple gestation. So when the mother has ruptured membranes is the first stage of labor, then you should do a VE to exclude called prolapse. Kindly note now when you go to the second stage of labor, that is the delivery of the baby, and you have already delivered the first baby. After you have delivered the first baby, you should not give oxytocin after the delivery of the first baby. This is because we predispose the second baby to asphyxia because of the contraction of the uterine arteries. Later, after the delivery of the first baby, you've already delivered the first baby, you have said not give oxytocin, you are starting the lie of the second baby. So if the lie is longitudinal, then you rupture membranes and wait for spontaneous delivery. However, if the lie is oblique, then you go for cesarean section. That is obvious and absolute indication of cesarean section. Later, you continue simultaneously do fetal monitoring, and if there's no contraction within 10 minutes, then you put this patient on oxytocin drip to augment labor, and then you deliver the second baby. Then, in case we have a retained subsequent twin that is greater than 30 minutes after delivery of the first twin, you consider cesarean section. So after now you have delivered the second twin, you palpate the uterus and ensure that there is no baby before giving oxytocin. Then later you conduct the active management of that stage of labor, and you examine the placenta for consanguinity and zygosity. Continue in addition now, that is the active management of that stage of labor involves giving of oxytocin to avoid PPH, that is postpartum hemorrhage. So you continue giving the IV oxytocin for 1 hour after the delivery of the placenta. So the role of cesarean section, now here we are going to divide them into two. That is the obstetric indication. So for example, this pregnancy, the patient comes in with malpresentation, comes in with malposition. These are obstetric complication indications. Or we have a complication such as preeclampsia. So twin related is, we already discussed this, when both fetuses or even the first fetus is non-cephalic, or for example that is breech or transverse presentation. So we said vaginal delivery can be done when both fetus are vertex, or at least the first one is at vertex presentation. I hope we are on the same page. So twin complication, we have intrauterine growth restrictions. So when you have these twin complications, it's also an indication for cesarean section. That is intrauterine growth restriction and conjoined twins. In addition to that, monoamniotic twins that share the same amniotic sac. And next is monochorionic twins, monochorionic twins with twin-to-twin transfusion syndrome. So in addition to that, collision of both twins at the brim, preventing engagement of the head of either of the head. So we already said you can deliver these twins when they are at vertex presentation. Now assume that both these are twins and both at vertex or at cephalic, and the heads come down. Both of the heads come down in the woman's brim, meaning that we have limited space. So that is absolutely indication of cesarean section because neither of the head can go to engagement. So the timing of this delivery, the optimum time to deliver uncomplicated twin gestation depends obviously on the chronicity and the amniosity. So as you have mentioned, we have twins that are, in terms of monozygosity, the twins that are monozygosity, we have di, we have mono, and we have mono-di. So I hope we are correct. We are in the same page in that. So in twins that are dichorionic and diamniotic, this division occurred in 1 to 3 days. I hope you remember the second slide that we talked about. They occurred in 1 to 3 days, meaning we plan gestation for uncomplicated in 38 plus 0 to 38 plus 6. This means 38 weeks plus 0 days to 38 weeks plus 6 days. In twins that are monochorionic diamniotic twins, this is when the separation occurred on the blastocyst, that is 4 to 8 days after conception, and then the delivery occurs at 36.0 to 36.6. So I hope we are together in this slide. So we have not, if you look at this slide, we have not talked about mono and mono. So that depends on the protocol that you use, but obvious the delivery of mono to mono should occur earlier compared to this this mentioned the above the listed two.